right, let's go ahead. Let's do the Kahoots. Kahoot, so it's going to go over these concepts. It's going to hit you over and over again, trying to make sure that you understand things like the medications that we use and some of the congenital defects here. Respiratory. It's a pretty intense Kahoot. All right, who wants to win today? Nobody wants to win today? Pediatric, respiratory, and cardiac systems. Number one, a majority of upper respiratory infections are caused by it's viruses. Whenever you think upper respiratory, you or I always think that's a virus, okay? Even croup and epiglottitis, all of them, virus, virus, virus. A multi. Down's children are more susceptible to which medical conditions? I start hitting you with this now because we're going to go over it again and again as we get to different chapters. You're going to see it. You're going to realize poor Down's children, they're born with all of these obstacles, and then there's so many more. They are apt for hypothyroidism, congenital heart defects, leukemia. So these poor children are already of all of this, and then they have all of these things to worry about. Actually, diabetes is not the one, though. We're going to say it again and again. Don't worry. You walk into a 6-year-old child's room and you find them not breathing and doesn't wake up. What are you going to do? Again, I told you, you're going to see CPR some way, somehow. Start chest compressions immediately, give rest, and then you call, right? You have to do one round first and then call up. So again, always review CPR. You're always going to get a question, whether it's choking, whether it's CPR. A multi. What are signs and symptoms that smaller children may exhibit that have a respiratory infection? So these children, they may or may not have a fever, even low-grade fevers. They feel miserable with them. Of course, they're not going to eat. If they're vomiting, you know there's something going on. And of course, their tummy's going to hurt. So any of these symptoms, you're going to say, what's going on? Multi. What do you look for when assessing respiratory function? How do you assess? So anything that has to do with respirations, I mean, you could actually look at a child. Are they breathing easy? Are they struggling? How fast? How deep? Are they labored? Is it easy to breathe, or is it none of the above? So again, just a visual, you could see all this before even listening. What would you look for after a child that has a tonsillectomy? So you're doing post-op care on a child just had a tonsillectomy or tonsillectomy and adenoidectomy. What is our biggest concern postoperatively? And the answer is we're worried about bleeding. Remember I told you about the scabs at the back of their throat and they could pop off and bleed easily? So if you have a child post tonsillectomy, number one, if they're not awake, you turn them on their side, okay? So that the blood can come out if they bleed. If you see them swallowing, that's probably there's blood in there and they're trying to swallow it out of their mouth. You see swallowing, probably look at the tongue, it's going to be blood. Concern if it's too much, does it need medical treatment or what? A multi. Nursing care for a child status post tonsillectomy include. Again, these are things you would have to teach the child and the caregiver. So we'll give pain meds as ordered, okay? Years ago, they used to give hydrocodone, and they found that these children are being overdosed at home. So they found only Tylenol works. So we give Tylenol for pain now. The gum is for those ear pain for the older people, and then an ice bag. Now, young kids ain't going to use it, but an older kid will put it there because that ice does give comfort from where that surgery was. Younger
I
kids not.
definitely overdosed on hydrocodone after my tonsillectomy
You
because the
see?
pain was so bad, the hydrocodone did nothing, and I kept taking it over and over and over again.
Yep. Not uncommon with it. And because we were seeing the overdoses in children, it's why they change of practice. It's just no Tylenol. And if it gets to the point you're that bad in pain, then you need to go back to the doctor. It's telling you something there was not right. Boy, but thank you. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? I think it's the most annoying. Okay, the tricky part of this one is to let you know tracheobronchitis, bronchitis is the same name. Okay, so bronchitis, dry, bothersome cough, keeps them awake at night. That's the classic definition. A multi. What signs and symptoms would you see in a child with otitis media? What's otitis media? So the one thing about ear infections, you don't always have a fever. With all of the ear infections I've had, I've never had a fever with it. But the pain, I've even had the eardrum rupture with purulent discharge coming out. And of course, you don't feel good, you're not going to eat. Kids always don't feel good, they ain't going to eat. Priority treatment on that child is going to be pain medicine. And you're going to say, why is it an antibiotic? Well, it takes a while for an antibiotic to work for the body. So the pain medicine will take care of that pain right away. The monthly immunization for RSV is respiratory syncytial. Remember, we can give it monthly for those children that immunosuppressed, premature, underlying conditions, that all that extra mucus is not good. So there's a couple names that you need to know for these two chapters. This is one of them, Synagist, Pavizumab. You're going to see it again. Synagist is given monthly for RSV. Hib is the hepatitis in the beginning. Indocin, indomethacin, closes the PDA. And Humira is a biologic for things like rheumatoid arthritis. So you know what they all were. A 4-year-old child's been taking meds for asthma and they're still wheezing. This information is important. They're taking their medicines. Why are they still wheezing? And what medicines does a child with asthma take? He takes his inhaler. And he's still wheezing. So this is a child, if they're still wheezing and they're taking it, I'd say, show me how you give that. And many times they can't push it and inhale at the same time. So again, putting a spacer on it. And it's even very, very small children that you don't think would do well. You take it, you put the little MDI on the spacer, and yes, they might cry, but they inhale really deep and get the medicine in. So spacers are really good to use. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Now, this doesn't matter, croup, doesn't whatever. An 8-month-old with signs and symptoms of respiratory distress, what do you see on an 8-month-old? That's where you're going to see retractions. And of course, respiratory distress means you're becoming hypoxic. So you become restless. So that is part of it. The other thing again is that nasal flaring and the grunting, that's only in infants, and that's also severe respiratory distress. Signs and symptoms of asthma include all except. Remember, asthma is that lower airway where you can get air in, but the problem is trying to get it out, right? Let me tell you, it gets trapped. So asthma, you're going to be hacking and coughing and all of those sort of things. Yes. Wheezing, absolutely, but it's an expiratory wheeze, shortness of breath, and they're going to have a prolonged expiratory phase. It's so hard to get the air out. They have to take an effort to go to try to get whatever they can out. So it's a prolonged expiratory phase. Signs and symptoms of congenital heart disease include all except. Congenital heart disease, the heart's working more, the body's taking more energy from it. So, what do you think a sign and symptom of that is? I'm working harder just to breathe and suck and swallow and breathe. That's it. Again, burning all the calories that they have because their hearts aren't beating effectively. So they have to beat more, burning more calories. Burning more calories, they're not going to gain weight properly. What should you not do to children diagnosed with croup and epiglottitis? Well, croup is swelling of the oral pharynx. Epiglottis is the epiglottis that's completely swollen and you can't breathe. So if you can't breathe and got swelling, you're going to put nothing in their mouth. You're not going to look in there. Maybe just look at the tip of a tongue, but you're not going to open and create more swelling. That's what the purpose of that question. A multi. Treatment for infectious mononucleosis, the kissing disease. Well, infectious mononucleosis is an Epstein-Barr virus. Antibiotics aren't going to do anything. It's rest, antipyretics, fluids, and protect that abdomen. Remember that spleen will burst and the kid will die. So no contact sports, protect that abdomen. A multi. When doing an admission on an infant that has a low-grade fever and a loose cough, what information is important? So you're admitting a child to your unit and you're getting the assessment that they have a low-grade fever and a cough. What do you need to know in order to place this child around onto your unit? What do you think? Well, number one, I want to know what their immunization status is. If they're fully vaccinated, I don't have to worry about things like pertussis, right? So immunization status. I want to know what fevers they've been having and when did you give your last doses of what? Apgar bursts don't tell me anything. That's not important unless they had a prolonged admission in the NICU at birth. But this, what they're telling you is this could be a child that has probably RSV. Do you put two RSV children together? And that depends, again, on the placement. Can you put that other child? Are they immunosuppressed? Can they be there also? And most of the time, they don't. What is the greatest risk for an infant having a cardiac catheterization? So the biggest risk is those two catheters that were in the right femoral artery and vein. It's that hemorrhage. Again, I will always check that dressing first. Older kids are going to have a sandbag on it, but it's a big pressure dressing on there to try to prevent it from leaking because it will. How is cystic fibrosis identified? So again, newborn screenings, they do this today. They do it on the pregnant mommy and the father of the baby. They're trying to do it that way. Not all of them get those screenings. So it would be at newborn, probably there would be no stool, especially if they're hypothyroid, and they will be doing what we call a sweat test. Cystic fibrosis, very important that we identify that. A multi. What is included in the plan of care for a child with cystic fibrosis? So remember, cystic fibrosis is a multi-system problem. It affects what? It affects lungs. It affects nutrition. So what do we need to do for this child? Well, we're going to have to do aggressive physiotherapy for the chest. We need to give those pancreatic enzymes with the meals, high protein, high calorie, and do not ever hold the sodium because they're losing it in their pores, in their skin all the time. So high sodium, give them a salt shaker. What is the drug of choice for pharmacologic closure of a PDA? The patent ductus arteriosus, how do we close it? Remember, I'm listening to that pulse pressure, go back to where it is, that pulse, that murmur is going to start to disappear as I'm administering this in 3 doses. And it's indomethacin. Indomethacin 3 dose, I'm going to hear decreasing murmur, and I'm going to see that pulse pressure come back to normal. What is not a feature of tetralogy of Fallot? Well, tetralogy of Fallot is a right-sided problem. So of all of those things, what's not right-sided? So the aortic valve is on the left side. Absolutely, that is not a tetralogy of Fallot. Now, as we're right here on tetralogy of Fallot, let me explain it to you a little bit more. When you have tetralogy of Fallot, the pulmonary artery, which means from the right ventricle, blood goes there to get oxygenated. Somehow that valve closes up and blood can't go up. It like spasms or a piece of tissue goes over it, something, blood can't go up there. As I said, my little Nolan went from 100 sats to 10, and it was within seconds. And the color was amazing, from pink to black. It was scary as heck. What do we do for tetralogy of Fallot? And there's something a nurse can do, don't need an order. Tetralogy, you'll be told to do it. It's what we call knee chest. We take their knees and push it to their chests, whether on their side or on their backs. And it changes the pressure in their abdomen and their chest, and it pops open that little pulmonary artery tissue and it lets blood flow. So, tetralogy, it's 4 things. It is pulmonary artery stenosis. That right ventricle was stretched out because blood can't get in there. It's going to be a hole between the 2 ventricles. And there's one more thing they call an overriding aorta. The aorta, because of the VSD, it sort of pushes it over. That's all that means. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, 32? What did I tell you about vomiting? No, I put all cardiac drugs here. Hydralazine, it's to decrease blood pressure. Metropropyl is a beta blocker. And allopril, again, it's also Vasotec. It also is used in cardiac issues. They are all used in children. But digoxin is the one that creates the heart rate to go low, and digitoxicity, big thing, it might be the only thing you see in infant, is vomiting. Why would a child with tetralogy of Fallot not gain weight at a normal rate? So tetralogy of Fallot is a congenital heart defect. Why don't congenital heart defects not gain weight? That's how you have to look at that question. Inadequate oxygenation, which leads to decreased energy to feed. And it's inadequate oxygenation because the blood's not getting to the lungs the way it needs. O2 sats are lower. You don't have oxygen. You don't have energy. You don't eat. And you don't gain weight. A multi. All are examples of cyanotic heart murmurs except let's see if you could figure this one out. So cyanotic heart murmur means they're not getting enough oxygen. So tetralogy of Fallot, I just told you, there are times where they don't get oxygen. Remember atresia, A without, there's no opening, so blood isn't getting into the lungs. So it is cyanotic. Excellent. Aortic stenosis, left side, they're already oxygenated, and an ASD has blood flowing from oxygen into non-oxygenated, and yeah, you got oxygen everywhere. Very good. A multi. Nursing education for the cardiac catheterization include all except. So child comes back from the cardiac cath. And what are we going to do? So post-cardiac cath, they must be on bed rest for 24 hours because the clot will pop off and they'll bleed everywhere. So that 24 hours is usually where they keep them on bed rest. The other thing is bending the extremity can cause that clot to pop. So we don't do that either. So no ambulating, keep that extremity straight. And of course, check that pressure dressing. Which information is the most important when rheumatic fever is suspected? Remember, rheumatic fever is due to a strep infection that wasn't completely treated. So, a recent episode of pharyngitis or sore throat could have been that strep infection. So, that would be the key thing. Now, there is a blood test you can take that looks at it in case you don't know, and it's called an ASO titer, anti-streptolicin titer. Streptolicin is right there in the name, and it's text, is there any strep in the body? And if it's positive, that's also the strep. Signs of shock in children include all of the following except shock. Shock in children, shock in adults is all the same. You're going to see most of the things. Remember shock, you said elevated heart rate, decreased blood pressure, decreased urinary output, prolonged capillary refill. I mean, these are all shocks that alter mental status, confusion, restlessness, all of those things. Hypertension, no, we wish, but their hearts don't work. Which of the following best describes the pathophysiology of Kawasaki disease? Multi-system vascularitis, which may affect the coronary arteries, causing an aneurysm, which will be, if that bursts, that would be the big deal with Kawasaki disease. I've seen many of these cases. A lot of it is the peeling on the palms of the hands and soles of the feet, which gives us the clue. They're not into the red eyes yet or the strawberry tongue yet, but you start seeing it on their hands and their feet first. A multi. A clinical manifestation of Kawasaki disease is urea is rheumatic fever. Remember, that's that movement that we can get back if we give long-term antibiotics. Kawasaki is a virus. It's that blistered, cracked palms, soles of feet. Yes, reddened eyes, strawberry tongue, broken lips too. Okay, could be a systemic rash and fevers, and the kid just feels miserable. What is the treatment for Kawasaki disease? Aspirin and IVIG. This is the one time that you do give aspirin to the children, and why? Aspirin is used to dissolve, help with the clots because it is an itis of the vessels, and we don't want those little microembolus causing any problems. It's a virus, so no antibiotics. Which of the following is the most common cause of shock in infants and children? And it's sepsis infection. Children don't have the body to fight it. So again, the biggest thing is getting infections and treating it as soon as we see it. In little newborn infants, the most thing that we might see is periods of apnea and bradycardia. And it's telling you there's something wrong just by the heart rate slowing down or respiratory rate slowing down. What are the defects associated with tetralogy of Fallot? Remember, it's right-sided. Tet spell, knee chest. Why? So it's that pulmonary artery stenosis, something happens that closes up, that VSD, the hole between the bottom chambers, the aorta sort of smushes over, and because blood can't get into the lungs, that right ventricle stretches, and that's called hypertrophy. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell. Now, most of your TET spells are, repaired before 1 year old, but there are some that are older. And, they're out in the world with this tetralogy of Fallot and they just squat. And it does the same thing, knee, chest. It goes from abdomen to chest, and it pops it open. Transposition of the great arteries. TGA is what? What does it mean? Transposition of the great arteries. What are the great arteries in a heart? That's the answer. So the pulmonary artery and the aorta are switched. This is the one where you have the pulmonary circulation and systemic now, and they're not mixed. This is the one that needs the oxygen giver, that needs that patent ductus arteriosus, and we need to give some prostaglandins. Keep it open, because mommy's gone now. Which of the following is not an intervention indicated for transposition of the great arteries? I didn't go over all of these, but there's one you need to check. I think transposition of great arteries is one of the exciting things for nurses. These children come in and we're going to be placing them on the prostaglandins. We're going to keep that oxygen giver open for that child. But there are times where that PDA is not big enough. So what they do is they go in with a catheter into the heart, make a balloon, and they punch open that ASD. You know, you're born with a patent foramen ovale, right? That little hole between the two atriums. Well, this thing makes it bigger. So now we're mixing oxygenated and oxygenated blood. So that's it. Nothing oral is going to treat transposition. There's no oxygen anywhere, so taking anything is not going to do anything. And then the surgery that they do in the end is called arterial switch. They just switch the top. They literally take off the top, turn around, and put it back on. Is literally what they do. Multi. Why is prostaglandins given to a child with transposition of the great arteries? What do prostaglandins do? And if you look at that box on this child, that is a temporary pacer. And they do use it. You see how small that child is? So prostaglandins, what it does, it gives oxygen where it's needed. So it helps with oxygenation. Also, it helps with cardiac output because now the heart can beat because it's healthy and it's got its oxygen. It has nothing to do, it's not an antibiotic. It's a hormone only to keep that PDA open. Mommy makes it by herself when the baby's pregnant. When mommy's gone, the baby's born, you have to give the baby back to prostaglandins if they have a transposition of the great arteries. Let's keep the oxygen giver open. What is the purpose of giving indomethacin to a neonate with a PDA? Why do we give indomethacin? Remember, PDAs sometimes stay open and we don't need them or want them. I told you many times it's in your premature infants. I see it a lot. So something's going on that's feeding that PDA, that hormone that keeps it open called prostaglandins. So what does indomethacin do? It says, wherever you're coming from, Mr. Prostaglandins, stop, and we need to close that PDA. Indomethacin, 3 doses. What do you see as you're given indomethacin? Decreased murmur, right? And you'll see that pulse pressure go from 60/18, you'll see go to 60/40, about where it should be. Where is the PDA? Patent ductus arteriosus, what does it connect? I've said it about 28 times. Let's see. I tell you it's an oxygen giver. So it connects the aorta to the pulmonary artery. The pulmonary artery gives the body blood oxygen. This heart defects allow bloods to pass from the left ventricle to the right ventricle. So if you have a hole between the ventricles, it's a septal defect. There's a septum in the middle. It's a septal defect. Between the ventricles is a ventricular septal defect. If it was between the two uppers, atriums, it'd be an atrial septal defect, or ASD. Remember, a PDA is the aorta to the pulmonary artery. It's nothing to do with ventricles. Doesn't touch the inside of the heart. A multi. What is a sign of ditch toxicity in infants? So, big thing, ditch toxicity in infants. They're not going to tell you they're seeing yellow spots. Sorry. They can't, nurse, I have yellow spots. No, you don't have that. What they're going to show you an infant is that they're nauseous, they're gagging, they're vomiting, or their heart rate's going to be low. Ditch has nothing to do with infection. Left-sided congestive heart failure causes what? So if the left side's not working, blood can't get out there. Where does that blood and that fluid go to? My heart's failing. So it's going to be to the lungs, which is going to be shortness of breath, fluids, coughing, gagging, all of that, decreased saturations, increase in body weight, all of those. After a heart transplant, what's the leading reason children die? Rejection, rejection, rejection. It's not infection, rejection. A multi. Signs and symptoms of rheumatic fever include the rheumatic fever. How do we get it? A strep infection that wasn't treated. You will see things like respiratory distress, that funny movement called chorea, the swelling of the joints called polyarthritis, and those subcutaneous joints. Remember, all of that can be reversed with long-term antibiotics, but if it's hit that mitral valve and there's damage, it's always going to be damaged. You're going to have to treat that medically or surgically. A multi. A child's about to have a chest tube removed. What should you do? Nursing care. Kid needs chest tube removed. Get ready. So, with children, explain it to them so they can understand it. Remember, they need to sit up. Laying down, that hurts. It's like pulling it straight out. Sit up, it feels better. Because remember, they're pulling it right out of the chest and the lungs to keep them open. Tell them, be honest. Don't ever lie to a kid. You lie to a kid, they're never ever going to believe you again. So don't lie to them. Tell them it's going to hurt a little bit, but you'll give them medicine and say, do you want me to hold your hand? Whatever it needs to be. And again, always medicate. Don't think kids don't have pain. They have pain that's real, just like yours and mine. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What do you need to do? They can't cough to expectorate secretions, and they just had their tummy surgery done. What do you need to do? All of the answers could be there, right? But number one, medicate for pain. Then you can move them and they're not going to hurt. You can get them out of bed. You can ambulate them. Then you could do incentive spirometry. Number one, medicate, medicate. Make them feel okay. An infant of 3 months has a fever of 103.6. What would you medicate this infant with? A 3-month-old has a fever. What do they get? Only Tylenol, acetaminophen. Only, only, only. Ibuprofen has something to do with platelet coagulopathy and bleeding. So we don't give an NSAID till 6 months old. And that's why I put this question here for you. A newborn infant is assessed and they find very weak lower extremity pulses. What should she assess next? What do you think is going on and how can she prove it? No, and very weak lower extremity pulses. What causes weak lower extremity pulses? Coarctation of the aorta. So, what do you do next? Do those four extremity blood pressures. What will you see? Because blood has a hard time going to the lower ones, lower blood pressures on the bottom, and the upper is going to be higher blood pressures. And that's how you say, hey, doc, I feel weak pulses. Here's your blood pressures, and he will know how to treat it. A multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? Now, you think that adults are the ones that are prolonged bed rest and they have all of these things, right? No. You have children that are in the hospital and ICUs for months because they're critically ill and they have same complications as does your elderly population. And what we need to do is, keep their lungs moving whichever way. Keep them clean and dry, whether they're changing their diapers, changing their uh, their chucks, whatever that is. And then with children, taking pillows and blankets and toys, I would always, especially with endotracheal tubes, we had beanie babies were a big thing. And they would bring these little beanie babies in, and I'd have it holding the ET tube looking at the child. And then I'd take the other blankets, he'd be hugging a teddy bear, and he'd have a blanket underneath his back and a blanket tucked in, and they just look so snugged in. And again, that keeps them up on their side, getting their lungs all moving the way that they should. Now, elevate the head of the bed. What does that do to help me prevent complications? Maybe respiratory. Now, it also depends. Does the condition let you elevate the head of the bed? How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? Infants. And the answer is oxyhood. Everything else will touch or bother them, or it's not accurate. So oxyhood is great. Clear plastic, they suck on their fingers and their pacifier, and they're just happy. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, their lungs are full of congestion and mucus. I call them like big petri dishes. And it's like the bacteria just love to go down there and grow. They're chronically on, antibiotic aerosols and PICC lines and antibiotics. This is a child that you do everything to keep their lungs at optimal, which means deep breathing and coughing and exercise, chest PT. Remember, with cystic fibrosis, we're going to be giving their aerosol to dilate, right? Then we're going to do this chest CPT to get rid of the mucus. Then we can feed the child. Another thing is to remember cleaning the equipment every day because it's pretty bad. A multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? How do you give pancreatic enzymes? When do you give them? How do you give them? And is there any precautions? Right? Take them right before meals, okay? Not 2 hours before, right before. Sprinkle it on the food with the capsules or the powder. You can put it on. Remember to rinse your mouth because it will hurt the teeth. And again, I think this is probably the biggest thing we forget. Children grow, increase the dose as we need it. What is the cardiac defect when there's no valve between the right atrium and the right ventricle? Right-sided, no valve. What's the name of that valve? The valve between the right side is called tricuspid valve. And it means no valve is an atresia. So tricuspid atresia. And last question, guys. When an infant is breathing fast, tires easily, and needs rest periods during feedings, what should you assess? What is going on that's causing this? So, test number 3. Number 2, hola.
That's
Number
me.
1, good job. And
Mimi.
Mimi.
Good job.
Good job, guys. So
Thanks.
this really hit a lot of your concepts. I know cardiac is hard, but if you can get through this Kahoot, you're going to be able to do the exam. Again, you're going to have your study guide, which has all the key stuff in there. Remember, you got your CJ Sims, you got your discussion question. Anybody who wants to go over the exam, send me a message. I'll be more than help you. That's all I got, guys. Have a good day.